could possibly talk about this morning. So, I'm going to start off with a story instead of a warm-up case, okay? Because you guys like stories, right?
Yes.
You like stories that, like, I was so cool stories, or do you like, this is when I was, like, frightened and, oh, crap kind of moments, right?
Yes.
Okay, I thought so, okay, because I don't really think I'm cool. Yeah, so, it was probably a year into COVID. I'm working in the emergency department at BAMC, and comes in a 44-year-old female, not previously vaccinated for COVID, states that she had tested positive for COVID the night before, and her husband brought her in, made her come in because when he touched her the next morning, he noticed that she felt cool and clammy. So he brought her in. She's hypotense, okay, she's like 80s over 50s. Her core temp is 95, that's rectally, so core temp. She's hypothermic from her sepsis, from COVID, we assume, because she was positive. She's satting at like 88% on room air. She looks kind of ashen in color. She just doesn't look right, right? And when you touch her, she's cold and clammy, okay? She's in clearly a shocky state, right? So she's also in AFib with RVR, and her heart rate's like 170. So is she unstable from her abnormal cardiac rhythm, or is it because of the underlying sepsis, which we suspect with her low temperature, recent fever, cough at home the day before she had a fever, now she's hypotense and clammy. So do an ECG on her. She has ST segment elevation everywhere. What does that mean? It's everywhere, every single lead. It's usually a pericarditis, okay? Which is interesting, and it brings us to this topic. It's relevant because the epicardium and the pericardium is not muscle, so it should not conduct. So why would you have elevation on tissue but it doesn't conduct, right? Just something to ponder about. Anyway, so she has PR depression, ST segment elevation everywhere. So I'm like, she's in an unstable rhythm, so what do we do with patients who are unstable and they're in a bad rhythm? We gotta shock them, okay? So here I am at the bedside, I'm giving her a little etomidate. I give her 10 of etomidate, I had a cardiovert, shock her, okay? I give her like 200 joules, because I don't mess around. And boom, and it didn't hurt me a bit. I didn't feel a thing. We shock her out of the AFib. She goes to sinus tachycardia. Blood pressure doesn't change. She's still hypotense. So we're doing fluids, starting to get pressors. I'm kind of freaking out. I might give you some epi. I need to do some push-dose epi. I call the code STEMI on her, knowing that it was probably pericarditis. I call the code sepsis. So at BAMC, we have so many resources that you literally have a STEMI team, you have a sepsis team, you have a code stroke, you have a code pink, which is, well, they call it different things now, but that's when like you have a precipitous delivery in the emergency department, which is a whole other story. Maybe Dr. Love will tell you about my precipitous delivery. But anyway, to get on task, this is why I'm not a good storyteller, is that this woman is circling the drain. I'm giving her a push-dose epi at the bedside, and her blood pressure's coming up very little, and she's kind of mentating, kind of slow. You can ask her questions, but she's kind of slow to respond. So her airway's patent. She's breathing at 88% or so on room air. We give her supplemental air. I'm bringing BiPAP to the bedside as well as the airway cart. She's on pacer pads just in case she becomes Brady. But now she's in a sinus tachycardia rhythm. And how do we treat sinus tachycardia? We treat the underlying cause. So I call it code sepsis. So this whole internal medicine team comes down, and cardiology comes down with them because it happens to be a cardiology attending who's on the medicine ward that day with the students. So they come in, they look at her ECG, they're like, this is definitely pericarditis, has nothing to do with the heart. And I said, sir, I think I'm really worried that she might have a myocarditis. You know, I hear a murmur, she's unstable, and he's like, anyway, we went back and forth, whatever. So they disappear, they're like, go ahead and do your workup, try to stabilize her, we'll get her to the ICU. So that's what happened, you know. So I'm throwing the kitchen sink at her, I'm doing a central line, we got fluids, we're doing pressors, repeat ECGs, you know, still ST segment elevation, do a trope, all the labs. She's basically comes back very high troponin. So by the time I walk her to CT to do a PE protocol, make sure she didn't throw a PE as well because of a lot of strain. Anyway, I walk her to the ICU. As soon as we get there, they call it code STEMI. okay? Because in their mind, even though it's pan ST segment elevation, the doctor there was like, it's more prominent in like 2, 3, and F. I'm afraid that she's having an inferior MI, and by then we already knew she had a positive troponin, right? So they're like, code STEMI. So cardiology comes in and was like, it's not a STEMI, but they start thinking maybe this is myocarditis, which is different than pericarditis, right? So anyhow, long story short, they do a cardiac cath, and guess what her, an ultrasound of her heart, an echo, guess what her ejection fraction was? It was low, very good. How low? Let me get some bids. What's normal? What's normal? Above 65, right? What just give me some, 20. I get 15, whatever. 8. 0. Close. It's 4. Like I've never heard of somebody having an ejection fraction of 4. And so she ended up there, and they were treating her, they were, vitamin C, all these stuff, and basically treating her like cardiogenic shock, basically treating her like a STEMI, but it was myocarditis. Anyhow, she ended up on the ECMO ward, and that's where, at that time, people went to die. And over the course of a few weeks, that she was on the cardiac transplant list because she had a dilated cardiomyopathy after her myocarditis, secondary to COVID, and she was on this cardiac transplant list, and she had no other comorbidities. And a few weeks later, her EF started coming up. It came up to 10, and 20, and like 40, and I think she kind of stopped around 40, 45. So she has chronic CHF now, but lived. Pretty amazing, huh? Isn't that a crazy story? And it just wraps in cardiomyopathies, pericarditis, myocarditis, all in one patient, right? That's awesome. I hope you never have to see anybody like that. My sphincter was so like the whole time. I mean, I know that's oversharing, but I'm just saying there were some of those patients that you're just like, oh my God, if I do one thing wrong, I'm gonna kill them. And that was one of them. So I'll never forget her. So cardiomyopathies and pericardial disease. What are cardiomyopathies? Did that record?
Yes, absolutely.
There should be some editing. There should be some bro code here, okay? All right, what do you remember about cardiomyopathies? They're very bad, thank you. They are bad. There's 3 main types, tell me. Dilated, restrictive, and hypertrophic. Man, you guys are awesome. Okay, of those 3, what are the most common? Dilated, why? Who gets dilated cardiomyopathies? I'm sorry? Yeah, that's a secondary cause, but who in general gets dilated cardiomyopathies? Okay, yeah, that's where it gets confusing. So unfortunately, people have used cardiomyopathy, the term, is kind of just a catch-all term. Hypertensive cardiomyopathy, ischemic heart disease cardiomyopathy, but the true cardiomyopathies are there's something structurally wrong with the heart or function. It's either alters the structure or function, and over time you can get that with hypertension, hyperlipidemia, ischemic heart disease. But in general, the people who get dilated cardiomyopathies are the people who are post-viral, like my patient that I just told you about with COVID, Coxsackie virus, people like that. Sometimes people are born with it. They have a sarcomere abnormality. People who chronically use cocaine or methamphetamines, they'll get a dilated cardiomyopathy. People who are chronic alcoholics will get dilated cardiomyopathy. So all of those types of folks, okay, and we're going to talk about it, all right? So these are my sources. I always provide specifically what you need in my slides. You don't ever have to go outside of my slides to know what you need for the test. As long as you know my slides and what I say, you'll be good. Okay, so we're going to talk about some of the cardiomyopathies and pericardial disease, the pathophys of it, and then how do we work these patients up? What do they present with? What are we looking for? How do we acutely treat them? And then what's our disposition? All right, make sense? All right. All right, let's talk about it. So we talked about cardiomyopathies or diseases that alter either their structure or function, or sometimes their electrical properties of the heart. You get primary, which are people that are born with them. They're just unlucky. They have some sort of sarcomere, and there's a whole list of genes that can be altered that can cause a cardiomyopathy. Okay, pretty interesting. Secondary ones, like our friend in the back said, are associated with specific systemic disorders, like ischemic heart disease, hypertension, your hemochromatosis patients with an infiltration into the pericardium, your sarcoid patients, people like that, they can get a secondary cardiomyopathy. But primary can be genetic, post-viral, things like that. They're the third most common form of cardiac disease in the United States, okay, so pretty big deal. All right, so we're gonna talk about dilated first because it's the most common, by far the most common. It's can be also familial, like we talked about, but a lot of other things cause it. Usually viruses, all right? Post-viral cardiomyopathies are bad. Has anybody here ever known a friend or a family member that was healthy otherwise and got sick and just never got better because there was some sort of hit to their heart? You? Yeah, there's a few. I know of at least a handful of people that this has happened to, and of course I've seen a lot more than that in the emergency department. COVID caused a lot of cardiomyopathies, a few cases of post-vaccination cardiomyopathy, very, fewer, I have seen personally fewer of those than I have the actual COVID causing cardiomyopathy, but any kind of virus can do it. It's a major cause of heart failure in the United States, and it's the most common form of cardiomyopathy. Also alcoholism, that causes a lot of cardiomyopathy, and then chronic methamphetamine use. All right, so how does it look if you have a dilated cardiomyopathy? This is a little video it should play. I know it's not in your slides, but do you see, just to orient you, this is the left ventricle. Oh man. Okay, this is the left ventricle, this is the left atrium, right atrium, left ventricle, right ventricle. So this is what's called a subcostal view of the heart. So the ultrasound probe is right here. And we're trying to look at all four chambers. And I know it's a little blurry, but again, left side of the heart is here. And the point of what you're supposed to look at is this dilated left ventricle, okay? And what that happens, when it's dilated, it kind of gets floppy, right? It doesn't hold the pump too well as it's, or can't really pump effectively. You should see those ventricles squeeze and really be hyperdynamic. And I'm gonna show you more videos later. So anyway, patients diagnosed with this are usually young, okay? So if you have, this is the classic scenario, you've got a 38-year-old person, post-viral, maybe they had some sort of URI a few weeks ago, and they're presenting to your clinic, or your ER, or your urgent care, saying, I've had progressive onset of shortness of breath, leg swelling, exercise intolerance, okay? Young people aren't supposed to present like that, right? You're not supposed to see young people with CHF, right? Who do we expect to see with CHF? Definitely old people. But you see some young person between 20 and 50, and you push on their legs and they have pitting edema and it's kind of new, you need to be having a suspicion of dilated cardiomyopathy. If they tell you they have a history of sarcoid or lupus or a recent illness, or they're a chronic alcoholic, or they admit it's that chronic meth head that always comes to your ER trying to drug seek, those are the people that get this, okay? So they have a high index of suspicion. They have dilation and impaired contraction of the ventricle. So they present with low output CHF. What is that also known as? HFrEF, right? You guys learned that? Heart failure with reduced ejection fraction. Like my lady I just told you about, 4%, is she HFrEF? Oh yeah. Okay, that's like the worst HFrEF I've ever seen in my life. Okay, and so over time that decreased ventricular compliance increases intracavitary pressures. And so initially they get left ventricular and then even right ventricular dilatation, especially with abnormal left ventricular wall thickness. And so anyway, the progression is dilated cardiomyopathy. And so how do we know that they have it? Well, they're going to present with signs of CHF. So tell me some symptoms of CHF. We've already talked about it, but I want to make sure you're with me. I know you're looking at what surgery? What's next? What's next? Actually, the second one kind of gets some people. So anyway, you didn't get that from me because I'm not going to gossip, but I still want you to pay attention, okay? It's right about the time, okay? Don't be changing your slides. We'll walk around. Okay. Give me some signs of CHF. Dyspnea on exertion. Okay, what else? Or just dyspnea, right? They can have dyspnea at rest. We had this conversation the other day. That can be bad. That's a worsening case of CHF. If they exert themselves, they have dyspnea. That's CHF. If it's progressed to a point where they can't even just sit there and do nothing and still have shortness of breath, that's a higher classification of heart failure. What else? JVD, orthopnea, PND, pedal edema. Sometimes there's so much edema, I've literally seen older men come in, they have a big protuberant abdomen, and their scrotum is ginormous, all from fluid retention, okay, seriously. Just last week when I worked in Uvalde, I had to do a paracentesis on this poor little lady that had cirrhosis of the liver, and she was having a presentation of CHF because she does have dilated cardiomyopathy in addition to her cirrhosis with ascites. And so anyway, they present, she had a lot of fluid. I think I took like 6 liters off of her, which is a lot. So anyway, when you listen to the lungs, sometimes they sound wet, and they obviously have some dependent edema. They can also throw a clot, and that makes sense, right? If the heart's not squeezing all the blood out completely and it's kind of just resting in there, it's very similar to like an atrial fibrillation, right? From this big dilated, so they can form a clot and throw it. And if they have chest pain, it's usually due to the limited coronary vascular reserve. It's not necessarily atherosclerotic disease. Why is that? If they have chest pain, it's probably because of the strain on the heart, not necessarily disease in the heart. Why is that? What population is getting this that I'm telling you? Younger people. They haven't had time to build up all their plaques yet. You'd have to really work hard to build up coronary artery disease in your 20s, okay? All right, diagnosis is typically made inpatient. So what do I do when I'm in the emergency department and I have a patient presenting like that? What do you think I need to do with them first? Yeah, make sure ABCs, always, safety net, all right? And initially, what do I want to do? Yeah, I want to do some sort of workup. You know, why are they having CHF symptoms, all right? Do a big rainbow of labs, right? A troponin, make sure this isn't some sort of infectious cause of their cardiomyopathy. A CBC, you know, infectious meaning myocarditis. Do a CBC, a chemistry, a BNP, right? All CHF patients should get a brain natriuretic peptide. What other kinds of things might I need to work these patients up? What else can cause a really acute strain on the heart and cause some heart failure? You could, you can ask them about their drug history. So if you suspect it's a chronic drug user, you can do a urine drug screen, all that kind of stuff. Pregnancy tests. Peripartum cardiomyopathy is real, okay? Women can present pregnant with CHF symptoms, and that's from a dilated cardiomyopathy, not from viral, just simply because they're carrying a child. So there's a lot of strain that goes on a woman's body during pregnancy, and this is one of them. So we're going to do a nice set of labs, maybe even a D-dimer in some of these folks if we think that they've had an acute PE, which has caused some sort of dilated cardiomyopathy. Usually a PE will put a right heart strain specifically, so it wouldn't be like, but if it has gone undiagnosed or they have a bunch of little tiny clots, it can put a strain on the heart and they can present with CHF. So we need to diagnose it first, okay? And again, definitive diagnosis means a formal echocardiogram. So my little bedside POCUS, I can suspect it, I can tell the cardiologist what I'm thinking, what I see on the chest x-ray, but the definitive diagnosis is made in patient. So your jobs are to recognize it, start taking some fluid off of them, okay, work them up appropriately and make sure it's not caused by something specific that you can treat and reverse, like they're severely anemic and they're having a high output cardiac failure from or heart failure. Treat all that, or what's another one that, like a thyroid disease that can cause this? I'm sorry? Yeah, that's kind of a CHF type picture too. A myxedema coma can cause it, and even a high output similar to anemia, they can have thyrotoxicosis. Okay, that can also cause a high output heart failure. Okay, so anyway, so diagnostically, we're going to do a bedside ultrasound, and you can actually see, as I'll show you some pictures, that dilated left ventricle. We always do a chest x-ray, right? Because it could be something underlying like pneumonia, pleural effusion. If half their lung is filled up with fluid, then maybe that's because why they're having CHF symptoms. But what do you guys see here in this chest x-ray? First of all, what age do you think this person is in this chest x-ray? I mean, really young. This looks like a kid, okay? And kids get this, and it's really terribly sad. So this is a kid with a huge heart, okay? That's AV normal. So any enlarged cardiac silhouette should cue you in. What other kinds of workup are we going to do? Everybody gets an ECG, right? Guess what? The ECG in these people are almost always abnormal. They're almost always abnormal. Usually you'll see left ventricular hypertrophy. Do we agree that there's a lot of voltage here? You guys remember about LVH? Okay, the S and 1, is that how we do it? How do we add it? Okay. That's exactly correct. And if it equals greater than 35 or greater, it's considered hypertrophy. So you don't even have to do any math to look at this and be like, there's a lot of voltage, this is some LVH, and that's usually what you'll see, right? In a dilated left ventricular cardiomyopathy, it's going to look like LVH because the left ventricle is dilated. They have left ventricular hypertrophy because it's all dilated. Does that make sense? A lot of times they can go into AFib and other rhythm disturbances, and if you were able to do a formal echo, they would have reduced ejection fraction. Remember, these are HEF-REF, reduced ejection fraction. Okay, I'm going to teach you how to do a quick bedside eyeball and be like, it looks like there's reduced ejection fraction. It's not going to be like you're going to say it's definitely 37.5% ejection fraction, but you can eyeball. I can give you a quick eyeball test, okay? Which is how we practice military medicine, especially as Army people. All right, we practice eyeball medicine, right? No? Sometimes. Well, we don't have all the tools. We have to make decisions, right? All right. Sometimes you have increased systolic and diastolic volumes. Sometimes you'll get a atrial enlargement. What does a P wave look like if the atria are enlarged? Yeah, they can either be like an M pattern, like a P mitral, or they can be really big and wide P waves, tall. Okay, that's a atrial enlargement. Again, for my exam, your exam, it's not mine anymore, I gave it to you, you're welcome. You have to just recognize ischemia, STEMI, that kind of stuff. I'm not going to make you pick out like left ventricular hypertrophy and LAE, even though in life you should be able to know how to do it. So, why do we do an echo? Well, we do it because we don't know why this person has heart failure, right? We also want to exclude heart failure that may be reversible. And then we want to estimate ejection fraction and rule out any other complications like a giant clot in there. And you can see that at the bedside ultrasound. So the definitive diagnosis for a dilated cardiomyopathy is what? A formal echo. How do you think we treat it in the emergency department or urgent care clinics? Do a POCUS, all those labs we talked about, chest x-ray, ECG, identify underlying causes, and then if they have fluid overload, what do we need to do? We're going to take it out, okay? And then that's going to be dependent. We're going to talk about that in our heart failure lecture. So here's a couple of pictures of a normal left ventricle. This is normal. Let me turn this off. I think it just looks better. Can you guys see it better?
Yes.
Okay. This is normal. This is the left ventricle. Now this is a parasternal long axis, and you guys are going to learn this quickly. So this is the ultrasound probe. Just like we read a map, it should always go right or up on the patient. The probe marker is always right or up. So that original view, when we saw all four chambers, we're right up here under the ribs, called a subcostal view, under the costum, okay, or the costal area. This is a parasternal long. This is the one time where the probe marker is not to the patient's right or patient's up. In this case, the probe marker serves the patient's left hip. You're just off of kind of like the fourth intercostal space, right, almost right on the sternum, but off the bone, because if you're right on the bone, you can't see anything. And this is what the heart looks like. And so just to orient you to this, what you can see at the top is the right ventricle. Because of where you are and what you're looking at, you cannot see the right atrium at all, and that's okay, we don't care. All right, this is not going to give us any information. What we care about is this right ventricle collapsing because there's a large pericardial effusion, and more importantly, what is this left ventricle doing? Okay, and so this is a normal left ventricle. This is the left atrium right here. So in between the left atrium and left ventricle, what is this valve? Mitral, very good, okay? And then this whole thing is ventricle, and it squeezes and pushes the blood out this valve out into the aorta. So what is this valve called? Aortic valve, very good. And so you can see what we call the entire left ventricular outflow tract here, okay? And so can you appreciate that when you look at this patient that has a dilated cardiomyopathy, that the left ventricle literally looks dilated, looks more rounded. Okay, you guys got that? I think so. I think it's obvious. All right. All right, let's just show you a video, okay? This thing today is trying to cut off my videos. So this is a dilated cardiomyopathy video, and what I want you to really pay attention to there is that these leaflets, when the heart beats, these leaflets in a normal hyperdynamic heart that's really pumping and going, like your heart, young people, these leaflets should come up and just flap and hit the ventricular walls. Just boom, that's a normal ejection fraction of 60, 65% or greater. I mean, it looks really hyperdynamic, but when it's dilated, it doesn't do that, okay? It looks kind of wimpy. So this is wimpy. You see that? It's not even hitting the other wall at all. Can you guys appreciate that? Just kind of flopping. So my eyeball test says this is reduced ejection fraction, okay? If the leaflets aren't slapping the ventricles, it's reduced, all right? Okay, so how do we treat? Well, we're going to treat just like I'm going to teach you in the acute heart failure, and it's going to be based on blood pressure. So if you don't remember anything else, I'm going to try to simplify heart failure for you acutely. All right, you guys paying attention? Okay, no HEMOC stuff? Okay, heart failure is put in 3 buckets, and it's based on the blood pressure. If they're hypertensive heart failure, we're going to treat the hypertension. If it's normotensive heart failure and they have signs of fluid overload, we're going to take fluid off of them. And if they're hypotensive heart failure, what are we going to do? We're going to give them pressors. So it's all based on blood pressure. It's the most simplest way to tell you to treat heart failure. This is acute exacerbation. This isn't your chronic management from your family medicine clinic. These are people that are coming in extremis with shortness of breath, fluid overload. We don't diurese everybody. What if the old lady has a little bit of edema, but she's septic and dry? I don't want to diurese her. Not everybody gets diuretics. And if they're hypertense, the diuretics aren't going to do anything until you address the major hypertension. They come in with a systolic pressure of 220. You better control that first. And that's how we treat these young people with dilated cardiomyopathies. If they have signs of CHF, if they're hypertense, we reduce the blood pressure. If they're normotensive, we can diurese them, like with a Lasix or furosemide. We usually start with 40 IV and titrate to see how much fluid we're getting off. And then the last folks, if they're in cardiogenic shock, they're going to need pressors, like dobutamine, okay, or push-dosepi, okay? ACEs, beta blockers, those are for outpatient chronic CHFers. We'll talk about, you guys talked about that last semester. That's not what you do acutely in the emergency department, okay? All right. So it's really nice if somebody presents to the ER and they say, hey, I know I'm only 40, but I had a virus 2 years ago and I developed heart failure and I'm having a heart failure exacerbation. It's really fantastic if they present and say that to you, because then you're probably going to take them serious, right? It probably is heart failure. But if most of the time in the ER, they'll come in and they just have these new onset of insidious symptoms, like suddenly I'm just getting worse and worse, shortness of breath, I'm starting to retain fluid, I've noticed I'm gaining weight, and that's going to cue you in for heart failure, all right? We're going to treat with nitrates if they're hypertense, diuretics if they are normotensive, and then make sure that they've been taking their medications if they've already been diagnosed with CHF. Maybe they're just having an exacerbation because they're non-compliant. Y'all are getting squirmy. Do you need a break? Okay. All right. And of course, life-threatening ischemia and stuff like that, we're always going to rule out. So I'm just going to do a quick, has anybody ever heard of an LVAD? You've seen one before, a couple people? I've actually never seen a patient with an LVAD. So it's a left ventricular assist device, and this is kind of one of those last-ditch efforts like ECMO, when somebody has such profound heart failure, like my little lady I told you about that had COVID and dilated cardiomyopathy and myocarditis. This is like a last-ditch thing where they can actually bypass the left ventricle with this assist device, and it squeezes the heart for them. And so instead of having like a systolic and diastolic pressure, they just have a constant systolic pressure at all times. Anyway, they have to wear this external battery pack, right? They actually literally are carrying like a little mani purse or a little, strap purse, and they literally have their battery pack, which is external. And it's just important because if they present cardiac arrest, you don't do chest compressions on these people, even though they just died. You just have to change batteries, okay? But if you don't have a battery and it's been a while, I guess we're going to do our best, because theoretically, if you're doing chest compressions, you'll dislodge the device and they could die. but they already kind of just died, so you kind of a little decision to make there. But anyway, it's just important to know that this exists, and this is a something that they can do as a last-ditch effort if a place doesn't have ECMO as they're waiting for their cardiac transplant. Okay. Okay. I think we should take a break. I feel like you guys are. It's only 8:30, but I feel like move on to hypertrophic cardiomyopathy. So just to reiterate, dilated cardiomyopathy doesn't have any hypertrophy. The myocytes in the wall are the same size, it's just stretched out. So if you had like a big fat thick rubber band and you stretched it out, it's the same thickness, but now you've stretched it out. That's dilated cardiomyopathy, okay? Hypertrophic cardiomyopathy is different. It's hypertrophy, meaning that there's more stuff there, right? And I know you guys have learned this already. Where is the hypertrophy? Yeah, it's kind of in the left ventricle, but there's a very specific area that it is, and that's why it causes an outflow obstruction. So it's an asymmetric hypertrophy of the intraventricular septum just under the aorta. That's why they used to also call it subaortic stenosis, because that hypertrophy is right where, when I showed you that picture a while ago, where the ventricle needs to contract and shoot the blood out to the aortic valve, that hypertrophy is right there at the top, just under the aorta, on the intraventricular septum. And so as people exercise and get more and more, cardiac demand, that thing gets thicker and it's going faster and blood can't get out. And that's why they syncophize, okay? That's why it's a big deal. I'm gonna talk about it. So it's a leading cause of sudden death in competitive athletes, rarer than dilated cardiomyopathies. Dilated cardiomyopathy is number one cause of cardiomyopathy. So this is less than that. Okay, great. It's hard to make the diagnosis in the ED, and again, we suspect it. If you suspect a young person who presented with syncope and you suspect hypertrophic cardiomyopathy, are you going to send them home? No, you're going to admit them for a formal cardiac workup. And if you saw them in your primary care clinic, and you did an ECG and saw these characteristic findings, or a young person with exertional syncope, and you suspect it, and you have a nice little ultrasound machine there, and you see that the left ventricular looks like there's some hypertrophy there, and I'm going to show you how to do that, and you're going to send them directly to the ER, and they're going to get admitted for a formal workup. As an outpatient, people with hypertrophic cardiomyopathy, they will get treated with beta blockers. That's the mainstay treatment of this disease, okay? But your job in an urgent care family medicine ER is to recognize it, and I'm going to teach you how to do that. Hear the characteristic murmur, see the ECG signs, see the bedside ultrasound, and then admit them. And then outpatient, they'll get beta blockers. You guys want to hear a story? You guys ever hear about Hank Gathers? Yeah. He was famous, Hank Gathers. Okay, so he's this young guy, I think he played for Loyola. I don't remember. He was a college basketball player. And he collapsed on the basketball court in front of everybody, and he was diagnosed with hypertrophic cardiomyopathy. It's kind of what put Holcomb on the map. And so he was treated, he fainted, they put him on beta blockers, and he tried to go back to playing, all right? He's cleared by cardiology to go back and play. But as he played, some people can't tolerate beta blockers. I don't know if anyone here has ever been on them. I've never been on them, thank goodness, but a lot of people can't tolerate them. They get exercise intolerance, they just can't tolerate them. Anyhow, he was on beta blockers. He's like, I can't stand this, I can't play. Went to the cardiologist took him off the beta blocker, and he was still playing. So guess what? During a basketball game, he was exerting himself, died right there on the basketball court, okay? Totally preventable. Of course, he was sued, and the family won because it was malpractice to allow him to play without being appropriately treated. So anyway, that's what put hypertrophic cardiomyopathy on the map, and they expect us, PAs, doing these little school physicals, to hear the characteristic murmur and decide who needs an ECG or not, and then clear somebody or not. And that's the responsibility on you, somebody's kid, right, that you may or may not have recognized. So this is important stuff. And I'll tell you, your board exam loves some hypertrophic cardiomyopathy, okay? The PAs love to ask a bunch of different questions about it, okay? So tell me what you remember about Holcomb. Is that how you guys learned how to call it Holcomb? Okay, that's how I call it. They try to take out the O and just call it HCM now. It's still Holcomb, okay? What's that? Okay. Okay. can get worse with certain maneuvers. We're gonna learn about that. And the reason why this one is easy to remember is because it's the opposite of everything else. Usually, let's say you have an aortic stenosis or any kind of other systolic murmur, when you squat, the murmur goes up. What's different about Holcomb is when you squat, it's gonna go down, okay? And so that's what makes it simple, and we can talk about other maneuvers. I'm gonna give you a bunch of different ones, that way you know it. But you get left ventricular wall thickening. Where did I say the wall thickening was? Yeah, in the intraventricular septum, and specifically where? Right under the aorta. Okay, that's why it matters. It's usually familial. This is an inheritable disease and disorder. So thanks, Dad, okay, for this. All right. Prevalence is only 1 in 500, and the mortality rate is actually less than 1% per year. Fortunately, not everybody who has Holcomb is actually active. You know, if the most active thing you do is play a video game, and the 10-year-old has acanthosis all over their neck from their diabetes and stuff, I mean, they may never get diagnosed with Holcomb, right? I mean, seriously. There are some folks that are in their 40s and 50s that are finally getting diagnosed with this because now they have so many other coronary artery disease and things like that, and now they're finally getting diagnosed, okay? So that's rare though, but you need to think about this in a young person who syncopizes with exertion or even has pre-syncope symptoms. Colonel Gendron should have taught you this. Which worse, pre-syncope or syncope? They're the same. Very good. They're the same. The problem is we think pre-syncope isn't a big deal, and we don't work them up. And those people go on to have a worse course. If somebody has pre-syncopal symptoms, especially with exertion, you need to run a full court press and assume that that's syncope. Yesterday at BAMC was syncope day. I saw like 6 people with syncope, and they were legit. Legit syncope. One lady broke her T-spine. One lady had a trimalleolar fracture from falling. I mean, these are legit syncope with no cause, no prodrome. Not your typical vasovagal stuff. So anyway, these folks take them serious, especially if they're younger, and it's during exertion is always bad. All right. Usually it's caused by inherent diastolic relaxation, but really it's restricted left ventricular filling, and the left ventricle can't squeeze the stuff out. So they may complain of things. What are some symptoms of pre-syncope that are related to the heart or syncope that they may complain of? I'm sorry? Yeah. They might complain of shortness of breath with exertion, kind of like CHF. They may say, hey, I just feel the sensation of a rapid heartbeat when I'm exerting myself, okay? And if you do an exam on these folks, sometimes they'll have an apical impulse or a presystolic lift, okay? Dyspnea on exertion is the most frequent complaint, all right? And that's because of exercise-induced sinus tachycardia. So as they exert themselves, they become short of breath. Because guess what's happening? The body and the brain and the rest, even the heart, the coronaries, aren't able to get oxygenated blood during exertion, all right? And then they could have chest pain, palpitations, and then lastly, pre-syncope or syncope, which is equal. And then a family history of sudden cardiac death should be a clue to cue you in, right? Did your mom, dad, brother, or sister ever have a heart attack or die at a young age of a heart attack? Did your mom, dad, brother, or sister ever have heart problems? Why do I want to specify mom, dad, brother, or sister? Oh my God, they'll tell you about their third cousin twice removed. I mean, it doesn't even matter, right? It's an immediate family history that's contributing, right? So I always get irritated. Like, I just had a new PCM appointment the other day, and they made me fill out, like, what did your grandmother's mother have? I'm like, who cares? You know, like, you just need to know about my mom, dad, brother, sister. Okay. But history of family, sudden cardiac death is bad. So usually if they do have chest pain, it's an imbalance. It's an O2 demand mismatch, right? And in older patients, maybe once they start getting coronary artery disease or atherosclerosis, they're going to have even more profound symptoms. Maybe they've never had them in their life. They may have atypical chest pain, and honestly, if they come in and they're older and they have coronary artery disease and they're presenting with chest pain from their hypertrophic cardiomyopathy that's never been diagnosed, you give them nitro, they actually have a pretty poor response to nitro. All right, so that's where it gets really confusing. But I'm not going to do that to you. I just want to plant the seed for your life, but I'm not going to ask you stuff like that. All right, so the S1 and S2 are usually normal. Okay, what are those? What's that S1, S2? Your love and your dub, right? Did they make you listen to heart sounds? Yes. Okay, is that kind of helpful? No. A little bit? Remember it? ventricular, yeah. I don't know. What's an S4? Well, you guys actually have an answer. I was gonna be like, I don't know either. I guess I have to know. Yeah, it's usually like an abnormal diastolic sound, right? Is that what you're saying? Okay, I think that's what you said. It's because of decreased compliance. Usually there's an S4, it's an additional sound. Okay, so what's some clinical features? Okay, what are you guys been taught when you're doing a clinical physical exam? What are you taught? You guys kind of told me a little bit about these maneuvers, okay? Standing in Valsalva decreases preload, so it increases the murmur. So these people are, what, preload dependent? Yes, no? Whatever I say? No, it's not whatever I say. All right, so standing in Valsalva decrease preload, so it increases the murmur. And then maneuvers that decrease the left ventricular filling decrease the murmur. So like squatting, every other murmur gets louder with squatting, but with hokum it gets softer. Murmur is characteristic and it worsens over time, and then it worsens when they this particular presentation of hokum, when you have the patient squat, it actually is different than all other murmurs. Did I just confuse you guys? Okay, so you're confused? You have
I was
questions?
just gonna ask, is Valsalva the same as squatting? Like, is that increasing the pressure in the interabdominal thoracic cavity? So it should be below, so it should decrease the movement?
That's right.
Okay.
Yep.
Thank you.
It's asymmetric hypertrophy, so of that symptom. So if you're just thinking about it in terms of outflow, it's anything that's gonna, so anything, if you reduce how full the ventricle is, it means that you're gonna increase the outflow obstruction, if that makes sense. Okay? I don't wanna get you guys confused. There is a chart in Tintinelli, and if you guys wanna remember this chart, that's fine. I think Valsalva and squatting is what I really kind of emphasized in my lecture, and so that's what I would pay attention to, just to recognize it versus other murmurs. Okay? All right. So we suspect the diagnosis in the ER. Did I go over that too fast with y'all? You guys already had this before, right? Okay. All right. Diagnosis is suspected in the ER. The other thing that we're going to do when we work them up is chest X-ray and ECG, right? All right. So we, just like dilated cardiomyopathy, where the ECG is almost always abnormal, it's definitely going to be abnormal in hypertrophic cardiomyopathy. Why? Yeah, because the left ventricle is hypertrophic, right? Even though it's an interventricular septum, it's going to show hypertrophy, and that's a characteristic finding. I'm going to teach you some other findings too. Okay, so they're going to, you're going to see that hypertrophy, but also you're going to look in the anterior and lateral leads, and you'll see Q waves. All right, some of them call them deep stiletto Q waves, stiletto heel Q waves. They're deep Q waves in the anterior and lateral leads of the heart. If you see that plus LVH, that is hokum until proven otherwise. So left ventricular hypertrophy with Q waves. Who gets Q waves? It's usually post-MI. So if you see Q waves in a young person's ECG in the anterior or lateral leads, that is hokum, all right? That is not some sort of pediatric adolescent variant, okay? That is hokum, all right? So LVH plus Q waves are bad in young people. And I'm going to show you some ultrasound pictures. So one of these ultrasound pictures is a normal ventricle, and we call this the fish mouth view. This is where we're literally able to cut the ventricle in half by our ultrasound machine and look at the ventricle. All right, one of these is normal, one of them is hypertrophy. You tell me which one looks like it could hold more blood. This one. If you're hypertrophy from the ventricle and they only have that much space to hold blood, and now you start getting tachycardic because you're exerting yourself, it's not filling, and therefore it's not pushing everything out. That's why they syncopize. The brain doesn't get perfused, and they get chest pain because the coronary arteries aren't getting perfused. Makes sense, right? Pretty common sense. All right, so here we go. Here's the difference. You did that same parasternal long ultrasound probes here, okay? The markers towards the patient's left hip. It's the only time we do a different view, and you guys will learn this in block 5. And we're looking right off of the heart here. Just to orient you again, this is the right ventricle up here. We can't see the right atria, that's okay, we don't care. This whole thing is the left ventricle and the left ventricular outflow tract, which is affected by HOCM. In HOCM, you get the thickening of the intraventricular septum, between the ventricles, intraventricular septum, just underneath the aortic valve, which is here. Do you guys appreciate that? Can you see it? Yeah, it's nutty, right? This is what gets thick, and it gets thicker and thicker, and then there's no way for blood to come out, and so they syncopize. Makes sense. And they can die. All right, and they do, unfortunately. Okay, so how do we treat it? In the ER, we're gonna recognize it, do our characteristics, ECG, chest x-ray, rule out other things, like your vasovagal and all those, silly things for syncope that always have the highest index suspicion. The two main causes of serious syncope are neurological reasons, right? Do they have a seizure? Do they have a brain bleed? Something like that? Do they have head trauma? But cardiac is the reason why people die with syncope, and so we're gonna make sure we rule this out. We're gonna do a bedside echo, and I was asked at break, it's kind of interesting, now the ERs that have ultrasound machines, when you put in orders, I'm putting in, okay, insert IV, O2 titrates 95%, give the patient aspirin, whatever I'm doing. I also will say point of care ultrasound cardiac, or point of care ultrasound musculoskeletal. And what happens is it goes up into the cloud, and so when I grab the ultrasound machine, I just select my patient, it pulls up, every image I save, saves, it goes back into the cloud and downloads into the patient's electronic health record. And so when you're doing a bedside ultrasound, like DVT ultrasound or whatever, I guess it's part of their patient's permanent record. So if you're seeing this at bedside, it's gonna be in their record, so when you call medicine and say, hey, I need to admit this patient to have a full workup because I suspect HOCM, they can actually see it, which is pretty awesome, okay? They can also see your terrible images too, and so then there's a little backlash, but whatever. Anyway, we're gonna admit them, they're gonna get a formal echo, and then as an outpatient, they're gonna be treated with a class of medications, which is the mainstay of HOCM, which is what? Beta blockers, very good, okay? We suspect it, we admit, beta blockers are the mainstay. I just gave a few slides here to emphasize that. Okay, now there's some other less sexy cardiomyopathies. The first two I talked about has reduced ejection fraction, right? The dilated cardiomyopathy has HFrEF, and you won't forget it because you're going to associate it with my little lady that had COVID and myocarditis. Okay, you'll know that dilated cardiomyopathies have decreased ejection fraction. Same with HOCM, decreased ejection fraction, right? Because there's really nothing to eject. Restrictive cardiomyopathies, like your sarcoid patients, your hemochromatosis patients, whatever, they have preserved ejection fraction. Okay, so they're not as sexy. They have some CHF symptoms, some shortness of breath, they have a cardiomyopathy, yes, but their EF is preserved. So guess what? They do pretty well. All right? So that's why I'm not going to give much attention to that. Are we cool with that? They're too normal to be serious about right now. Okay? Let's move on to the sexy one. You guys actually learned about Takotsubo, right? What do you remember about Takotsubo? First of all, what is a Takotsubo? It's a Japanese word that means octopus trap, right? And it's really crazy. So what causes Takotsubo? They're heartbroken. Yeah, I think one of my first little things I had to publish was like the broken heart syndrome. Because I'd never heard of it. They didn't teach us this in IPAP. Remember, they didn't teach me anything in IPAP, okay? I'm just kidding, mostly. Anyway, the broken heart syndrome, and I've seen this a lot. So the typical patient is like a little old person that has a history of like hypothyroidism, and they had some sort of catastrophic, they're in their 70s or 80s, 70s usually, and they had some sort of catastrophic, terrible life event. Usually the death of their spouse, right? Or the death of a child. And they come in the very next day, they have chest pain. What does their ECG look like? Definitely a STEMI, and you cannot distinguish it. It looks so STEMI. It could be anterior, it could be lateral, it could be inferior, it could be anteroseptal. It doesn't matter. It looks like a stone cold STEMI, and they present with heart failure too. So they have a STEMI and heart failure. What happens to them? They get aspirin, they get nitro, they get heparin, and they go to the cath lab for PCI. And then what happens when they're in the cath lab? They're like, the coronary arteries are clean, okay? So if these people don't die within the first 24 hours, they usually go on to do okay, but they can die of this. And I saw a case, unfortunately, in Uvalde the day after the shooting. One of the gentlemen, whose family members were killed the day before, came in, had Takotsubo, and legit passed away from it. And it was Takotsubo. They took him to the cath lab, and he died in the cath lab, even though his coronary arteries were clean. Okay, it's just terrible. And they think it's that surge of stress catecholamines that do this to the heart. They really don't understand the pathophys, but once they get into the cardiac cath labs, they have this distinguished shape of the heart. It's like an apical impulse abnormality at the apex of the ventricle. It has this like little vase shape, and they can't quite figure it out, okay? On ECG, it can be indistinguishable, like this is a giant one, this is a STEMI, right? And the anteroseptal leads, okay, V1, V2 is septum, V3, V4 anterior, even V5 and V6. But when they get to the cath lab, their coronary arteries do not have coronary artery disease. And they will have some degree of CHF, they'll have to be placed on beta blockers, all that stuff. So again, if they make it through the first 24 hours, they usually go on and do okay. All right, y'all with me? We need another quick break? No? You sure? All right, we're gonna get through this. We're not too much further along. Okay, so pericardial disease. We talked a little bit about this. Pericardial disease, what is that? You guys are nailing it. It's disease of the pericardium. All right, awesome. Okay, and we talked a little bit about it. There's a difference between pericarditis and myocarditis, and I try to identify that up front. And sometimes you can't tell. And what have you guys have been taught about the ECG in pericarditis? Diffuse ST segment elevation everywhere with PR depression is the buzzword. But guess what? One, the pericardium doesn't conduct, so it shouldn't affect the ECG. Okay, so some of that teaching is incorrect, although there is characteristic association. And number two, it only happens within the first week or so of the pericarditis. After that, they're going to have a normal ECG and just have that that pericardial rub or positional classical chest pain. But you're only going to see ECG changes of ST elevation and PR depression in stage 1, and only if it's such a severe pericarditis that it's irritated the epicardium, or worse, it's an actual myocarditis. All right? So you're saying, now I'm really confused. So if I see this pattern, do I need to work everybody up for myocarditis? And the answer is yes. If you see those characteristic ECG findings for a pericarditis, you should be looking and making sure they don't have myocarditis. Okay? Is that new? Should be new. That should be a new concept because people are not catching up with the literature. Okay, so the pericardium is this like little loose or fibrous membrane, and usually in between the epicardium and pericardium or the visceral and parietal layers, there's a little bit of physiologic fluid. It's about 50 cc's, okay? And that just keeps those two layers kind of sliding on each other. 50 cc's. And it's so scant, but we can actually see that a little bit amount on the bedside ultrasound. We can actually see a little bit of fluid. A little bit of fluid is normal, all right? But it's obvious when you see a large pericardial effusion. Anyway, so these are the most common causes. Most common cause is idiopathic. Anytime something's idiopathic, it's because we're idiots. We can't figure it out, right? That means we just don't know. The second most common cause is Coxsackie, and I've seen a lot associated with COVID or even certain vaccines. And some of it's not necessarily the vaccine or some of the products in the vaccine. But anyway, uremia can cause that. What's uremia? Kidney issues. And what does it look like on lab-wise? LWN, creatinine, good. Trauma. How can trauma cause acute pericarditis? What's that? Yeah, blunt trauma. Very good. Not wearing your seatbelt, you hit the steering wheel, you can irritate the pericardium, even bruise it. Okay, autoimmune. What are some autoimmune disorders that can cause pericarditis? I told you a couple already. Lupus is really a common one. Sarcoid. Okay, what else? Anything. Any autoimmune, okay, can cause it. Malignancy. Malignancy can cause pericarditis. So if somebody had breast cancer, they can get pericarditis, not because of proximity, just because of the what's going on in their body. It's almost like an autoimmune response now. They can get a pericarditis and a large pericardial effusion. And then lastly, fungal infections. How unlucky is that? Okay. All right, so what are some symptoms? You guys know this. We don't have to teach you and make you read a slide. What are symptoms? Yeah, that it hurts worse when they lean forward, feels better. Is that right? Or no, it's the other way. It gets worse when they lay down and feels better when they're leaning forward. And so when you listen to them, it gets worse when they lay down, right? You get it, for sure. We got it. Okay. It feels better when they're kind of leaning forward. When can we hear the pericardial rub the best? When they're leaning forward. Okay, very good. And so they can have referred pain, sometimes to the trapezial ridge. Sometimes they'll present with like a pleuritic chest pain. And you're like, man, is this a PE? Or whatever, you know, you start kind of running down the gamut, you know, and so that's why they get the chest x-ray, they get an ECG, they get a workup, and depending on their age, they may get a natural reflex troponin. Sometimes they'll complain of like shortness of breath or inspiratory pleuritic discomfort or shortness of breath or dyspnea. Sometimes they'll even complain of dysphagia, difficulty swallowing or pain with swallowing. Why is that? Yeah, it's irritation. What runs right along the pericardium, the esophagus is pretty close, and they're all innervated by the vagus nerve. All right, so physical exam, what do we expect to hear? Yeah, the friction rub, okay? And it's best with the diaphragm of the stethoscope, left lower sternal border, patient leaning forward, like we just said, and you'll hear it. And it's very distinct. It almost, it's like sandpaper or like a little crack sound. I can't really do that really well, but anyway, that's what it sounds like. It's a very distinct rub. But you guys already know your heart sound, so I don't have to like act it out, okay? I'm not a very good actress. All right, so typical, we're gonna do our physical exam. We're gonna get good history, PE, like a physical exam. Do an ECG, a chest x-ray, bedside ultrasound, and I said plus minus troponin. We're gonna do a troponin on everybody that has like positional chest pain when they look fantastic and their ECG looks normal. Probably not. I mean, but are you wrong to be conservative and do it? You're never going to be wrong, okay? It's just a little extra money, but that's okay. It's not out of your pocket. And TRICARE, they like to, you know, underpay clinicians and cover you. So it's no skin off anyone's teeth if you do it. But you definitely need to do a troponin if they're older with comorbidities or they have an abnormal ECG, 100%, okay? Or there's some other characteristic findings that would prompt you to want to do a troponin. What other thing? If they look sick or septic, they're severely tachycardic, or they're febrile with their chest pain, you should probably do a troponin. Okay, you need to make sure. And so there's a list here in just a few more slides. So fever, ECG changes, any kind of high-risk features, like the patient's immunocompromised for some reason, just err on the side of doing a troponin. And if you decide to do it on everybody you suspect has pericarditis, that's the way you want to practice, that's okay. Guess what? You won't miss a myocarditis. Okay, that's good. All right. Here's what the characteristic ECG changes are in the stages. So what I said again is it's only in the first couple of weeks, stage 1 of 4 of the pericarditis that they would have ECG changes at all. And it's only if the pericarditis is so bad it's irritated the epicardium, or worse, they have a myocarditis, that you should even see this. And it's only in stage 1. Which stage does it happen in? Stage 1. Okay. These other 3 stages, within a few weeks, they'll get like some isoelectric stuff, everything looks normal, they'll get little T-wave inversions, which almost looks like Wellens, which gets you all confused. And then they go back to normal. But the other 3 stages could take days, months, even years to accomplish, okay? So anyway, if you're lucky enough to catch them early and you see any characteristic changes, that's even nice. But this is what it looks like. So looking at this ECG, this is your typical PR depression everywhere, okay? PR depression, just barely, you know, you can barely see in some of the areas, a little PR depression here. And then PANS ST segment elevation. So which stage is this? Stage 1, all right? Good. That's what it looks like, okay? So it looks weird if you see ST elevation everywhere. Usually it's just one particular artery. Sometimes you're unlucky and you can see a true STEMI in multiples, but you're not gonna suspect that in a young person who's just said, hey, I had a viral illness last week and I have this weird chest pain now. That seems to be positional. That's usually the classic finding, and most of the time these people can be sent home with just NSAIDs and colchicine. Here's the further stages. It kind of gets isoelectric, and then eventually they'll have, I don't know what just happened. And then eventually they'll get T-wave inversions and then goes back to normal. All right? Getting through it. So diagnostics, they can, even if it's just viral and they're otherwise well, they can still develop a large pericardial effusion. So you always want to do a bedside point of care ultrasound to look at the heart. Those same views, subcostal and parasternal long views, are the only views you need to see if there's a large pericardial effusion. You can also tell if there's tamponade physiology by those, and that would be the worst complication of this, is so much fluid collection that they get a tamponade physiology, okay? Or myocarditis, which is bad. So we do an echo at the bedside, and then if you want to admit them, if they have any high-risk features, and they'll probably do a formal echocardiogram while they're admitted. And so if the pericardial effusion is present, then that space fills with fluid. So just to give you another couple of ultrasound views, this view here is called the subcostal, also called subxiphoid. It just means same thing. So the ultrasound probe is here underneath the patient's xiphoid. The probe markers to the patient's right shoulder, not yours, the patient's right shoulder. And this is what you can see. You can see the left atrium, right ventricle, left ventricle. And if you see this little black line around it, that's physiologic fluid. Fluid on ultrasound looks black, okay? It's almost hard to see. And what you really see is this hyperechoic or white surface lining of the two visceral and parietal layers coming together, and on ultrasound it makes it look super white. So you should be able to see the, around the heart pretty distinctly, all right? Versus this one, where you can actually see a distinct layer of fluid in between the two cardiac layers. It's hard to see, but it's even so much that when we get up to the top of the image, there's actually a big fluid collection. That's a pericardial effusion. And if you see that, the next question you want to ask is there tamponade? What's physiology of tamponade? What is the blood pressure of somebody in tamponade? It should be hypotense. So you should have a clue that, hey, this isn't just your run-of-the-mill pericardial effusion. Then you look at the right ventricle on this view, and if it's collapsing during diastole, then that's tamponade, okay? And what do we treat first with? What do we treat tamponade first? The first thing we do is give them IV fluids. You're going to give them an IV fluid bolus, 500 cc's to 1,000 cc's. That's the first thing you do. You don't just start jumping up in there, but you're absolutely correct. The definitive treatment would be a pericardiocentesis at some point. All right, so most of the time though, patients who present with pericarditis, it's just a little irritating, inflammation, and you can treat them with NSAIDs, like an ibuprofen, 3 times a day, plus colchicine. Why do you want to do both? It prevents recurrence. Very good. Which is the exact reason why we don't give steroids. For whatever reason, by study, even though we know steroids are potent anti-inflammatories, when we give steroids for specific pericarditis, it actually worsens the recurrence or increases the recurrence. And the only thing worse than having pericarditis once is having it twice or 3 times, okay? All right, so ibuprofen, whatever, somewhere between 300 and 800 milligrams 3 times a day, no steroids, and then colchicine twice a day. And we usually do that for, about 7 to 10 days as well. You can do it up to 2 weeks or so. Usually we don't have to hospitalize people. Usually we're so sorry of your unfortunate pericarditis. You just had that virus. This should make you feel better. Come back if you start having shortness of breath, dyspnea on exertion, orthopnea, lower extremity edema, or any of those signs of CHF or difficulty breathing, because that might mean that it's progressed. So back to myocarditis. How do we know if it's pericarditis or myocarditis? People with myocarditis are sick, okay? They are sick, okay? They don't just happen to be bopping in and they're eating, drinking, pooping okay, living their life with just a little bit of inconvenient chest discomfort. These people are sick. They have a fever. They look sick. It takes several days to weeks for it to come on, usually, with the exception of my lady with the COVID. That happened like overnight. These are high-risk features. Fever, Subacute, like it's really been going on for several weeks and it's just getting worse and worse. Have a high index of suspicion that now that virus has infiltrated into the muscle. Okay, you see those characteristic findings on ECG plus any of these. Or if they're immunosuppressed chronically, like a, who's immunosuppressed? I'm sorry? Cancer patients, who else? HIV patients, who else? Transplant patients, very good. Those are all immunosuppressed patients, right? Or if they're on anticoagulant use, for some reason that increases the incidence of myocarditis, all right? And then of course those elevated changes on ECG plus a positive troponin. That's myocarditis all day long, okay? So that should make it simple for you. And you're never wrong, you're never gonna be wrong for going ahead and doing a troponin on somebody that you see changes on and just making sure, okay? All right, so another complication besides death of their myocarditis, because we missed it, or they just succumb to their illness, would be a large pericardial effusion that progresses to tamponade. And we already talked about this. It's not how much fluid is in there, it's the rate of accumulation. So typical scenario, I'm working at BAMC, patient presents, stab wound to the chest, some sort of Bible study situation that just went bad, okay? I'm just kidding. But that's what they always say. They say, I was just minding my own business and somebody stabbed me for no reason. I was literally reading the Bible and I just did a humanitarian great effort and I got stabbed for no reason, right? So that's what they usually say. Okay, so they get stabbed, the pericardium fills up super rapidly, a couple hundred cc's, they have tamponade, okay? Because of their anterior stab wound, it filled up super quick. People with autoimmune diseases, they can carry up to 500-600 cc's in that pericardium because it gradually kind of builds up over time, just slowly, days, weeks, years. They can carry several hundred cc's before they finally present with some sort of symptoms. So again, it's not the amount, it's the rate of accumulation. So anyway, so suddenly increase in fluid changes the intrapericardial pressures. If it continues to accumulate, the pressure rises, and then the filling pressures are affected, and then the patient starts presenting with symptoms of CHF. So once they come in and they're actually in tamponade, they're hypotense. You're so smart, you do a quick bedside ultrasound, because you can look at a couple of different things. You're gonna look at the pericardium, you see this massive pericardial effusion, okay? And so now the patient's hypovolemic because the filling, the ventricular filling pressures have been so affected by that fluid accumulation. And this is what it looks like on ultrasound. Heart is beating, okay, and it's in this big thing of fluid, okay, it's just kind of sloshing around. What would an ECG of somebody like that look like? Electrical alternans, little beat, big beat, little bit, big beat, because it's definitely floating around in there and it's just kind of slinging around in that fluid, all right? And so what you can hardly see at the top here is that the right ventricle is collapsing. That's tamponade. So first treatment is what? Fluids. Why do I do that? Because the right ventricle is collapsing, they're preload dependent. I want to give them more stuff in the tank first, try to stabilize them and bring up their pressure so they can get that cardiocentesis in the OR. We don't want to be doing that kind of stuff in the ER unless we have to. And trust me, if you had pericardial effusion with tamponade pathology, you would not want us to be doing it in the ER. Not because we're incompetent, but because back in the day, we'd take a big spiral needle with a 60 cc syringe, and we kind of eyeball it under your subxiphoid and aim it towards your left shoulder with some backwards pressure. And then once we got onto the heart, theoretically, that fluid would start just going into the syringe. Go a little too far, like, whoop, sorry, I just stabbed your left ventricle, so not good, okay? So it's better to be controlled, but now we have ultrasound, so we'll actually do it ultrasound guided, and you can see it in real time when the needle goes in. I'm gonna show you in just a moment. So this is just some causes of non-traumatic tamponade in patients. It's the same thing that causes pericarditis, right? Uremia, infection, Coxsackie virus, all that kind of stuff. All right. We talked about this already. It could be an underlying medical problem like an autoimmune disorder, post-viral, whatever, that's what can cause it. And then you may also have a pulsus paradoxus. All right, heart sounds, what is that the famous triad that I've never seen in the emergency department? Beck's triad, okay? I mean, almost never do they have that, but can you remember? and the crypts of your mind, what those things are.
Muffled
Muffled heart sounds, JVD, hypotension. Dang, okay. You guys are, no, I'm not just saying this, but you guys seem to have retained a lot more from last semester than most senior classes. So kudos to you. Hopefully HEMOC won't get you. Anyway, I'm just kidding. It's just a joke. Come on. All right. So chest X-ray. What do we expect to see on chest X-ray?
A large heart.
A large heart. Thank you. All right. And then on ECG, we just talked about it. Yeah, electrical alternans if they have tamponade. This is non-traumatic tamponade. So just to remind you what a normal heart looks like versus AV normal. Okay, normal cardiac silhouette, abnormal. Sometimes it's a little tricky. Okay, this patient tried to be tricky Ricky because it looks like the cardiac silhouette on first glance isn't too bad, but then if you really look, you can see the pericardium's way out here, and this is a dark fluid. Okay, so that's kind of confusing. All right, and here's your typical ECG of a large pericardial effusion. Maybe not so much tamponade. This is the rate is 300 to 150, so maybe it is starting to be early tamponade. But you can see the electrical alternans: big QRS, little QRS, big, little, big, little. And it's because again the heart is just sloshing around in all that fluid. I always get excited when I see this, and sometimes I've seen it and then they absolutely don't even have a pericardial effusion, or it's not every beat, every other beat, so it gets confusing. But anyway, so diagnosis should be suspected. We do a chest X-ray, bedside ultrasound called point of care ultrasound. We see the pericardial effusion. If we see a pericardial effusion, what are we looking at specifically to see if it's a really bad pericardial effusion? The right ventricle. If it's collapsing during diastole, that is tamponade, all right? And that's important because you're going to need to do that even for trauma. If somebody's right ventricle is collapsing during diastole with a large effusion from that stab wound, from that Bible study gone wrong, that's tamponade, okay? And so they'll see the, at bedside ultrasound, you'll see the large pericardial effusion, maybe even some right atrial compression if you do a subxiphoid and you can see all four chambers of the heart. And then the most important pathognomonic finding other than the large effusion is that right ventricular collapse, okay? And I know it's hard to see, but here's a picture of a pericardial effusion causing tamponade pathology. This is the right ventricle, and you can see it's barely even opening, okay? Hardly, not much going on there, all right? Let's show you another view. This is a subcostal or subxiphoid view. So we've got right atrium. Why does this, you know why? It's because it's the medical center of excellence.
Oh yeah.
All right, right atrium, right ventricle. See how the ventricle is collapsing during diastole? That's tamponade. And of course you saw the large pericardial effusion around it. Does anybody need to play it again? It's going so well. I can play it again. So all this black stuff around the heart is fluid, and this right ventricle is collapsing in between the beats. Right there. Boom, boom, boom. Collapsing. How about this guy? It's a little more obvious. Huge pericardial effusion. This is the right ventricle. It's not even opening at all. All right? So patient presents, they have large pericardial effusion. You see it at the bedside. You see the right ventricle collapsing. First thing, we're going to have a fluid bolus, 500 cc's to 1,000 cc's, and try to stabilize them. If all of a sudden they die and they go asystole, how do I treat that? Thoracotomy. We do a thoracotomy. We're only breaking chest open if a patient dies in your ER, okay? If we can stabilize them, we can do a pericardiocentesis. But once they're dead, you have to open them up and actually do a pericardial window. We don't do pericardial windows on live patients, even though we know they have a tamponade. Okay, we don't crack open their chest and do a pericardial window. Now, if they take a large pericardial effusion tamponade patient that's been stabilized from the ER and they can make it to the OR, this CT surgeon may decide to do a pericardial window for whatever reason. They may actually go in there, but we don't crack chests open on anybody in the ER unless they just died. And in which case, we have to get up in there. We don't have time to mess around with the syringe and tool around. We have seconds to try to get that fluid out of their heart so that we can restart their heart. So even if you did a bedside ultrasound, you know it's a tamponade, you're giving them fluids, they just didn't respond, they crumped, Now you gotta do a thoracotomy. Make sense? Alright, usually we have to do that during trauma. Alright, so volume expansion is the first thing, it's only temporary. We're trying to buy ourselves time to stabilize the patient, get in the OR. If for some reason they can't become stable and they didn't die, then we are going to do a pericardiocentesis in the ER, and I'll show you a little video of that. But this is on a pig heart, so that we didn't actually do it on a patient who's dead. So how do we do it? We put the ultrasound probe right on the heart, okay, and we're looking right over, and we're going to look at the maximum area where there's a lot of fluid, and you're going to take like an 18 gauge needle with a large syringe, and we're going to go ultrasound guided, and you can actually see the tip of the needle going in through the chest, all right? I wouldn't say it's not painful, so you might want to do a little local, okay? And then a lot of times now we'll go right on the anterior chest in the fourth intercostal space, just lateral of midline, so kind of the nipple line. We'll go directly in, and then we'll put a little pigtail catheter, almost like an IV catheter, to kind of leave it in there because whatever caused the effusion may continue to accumulate. We don't want to re-stick them, right? You want to be re-jabbed. So sometimes we'll put a little pigtail catheter. This is a swine heart in the lab that we used to do, emergency medicine labs. We always do pig labs. And this is we induced a pericardial tamponade on this swine model. Unfortunately, they passed. But here's a real-time video of the needle coming down and entering into the pericardial space. And then we just have negative pressure on that big 60 cc syringe. And as soon as we start getting fluid accumulated, we don't go any deeper, and we just start pulling the fluid off. And then if it fills up the whole syringe and there's still more fluid, we stabilize the needle, take off the syringe, put a second one on, pull back, or even better, if you had a stop cock on there first, you can just and then get it all out. Okay? It's cool stuff. All right, any questions? I gave you a take-home point slide just to remind you what we just talked about this whole time when you were looking at hematology, oncology. What is your test about? Like, give me an oncology specifically? Cancer stuff? Multiple myeloma, what else? Polycythemia vera? Okay. That's some tough stuff. Did anybody here have an interest in going into hemonc? I'll tell you, the hematology, oncology people and the pulmonologists are probably the smartest people in the hospital. I mean, they are amazing. You have to really deal with folks. Don't tell the surgery or the neurosurgeon people that, okay? This is where I like to tell my surgery joke. What's the difference between God and a surgeon? God doesn't think he's a surgeon, okay? Tell that in your surgery rotation with phase 2. They'll love it. Do you guys have any questions about what we went over today? The next time I see you, I guess, is what's today? Yeah, today's Friday. I don't see you till Monday. Is that right? No, I see you Tuesday. I don't think I see you Monday. I don't know, Monday or Tuesday. We'll do aortic dissection and heart failure. Those are two tough topics. And then the last one is VTE. And then we'll have one class period, which is Thursday before your surgery exam, which will be nothing but review, answer your questions. I like to do like a little fun Jeopardy game, try to make it competitive. But if you guys aren't really competitive with each other, it's not fun for me. Are you guys competitive with each other?
We're very apathetic.
You're apathetic? Okay, well, I mean, we don't have to do that. Let's try it.
Oh, yeah.
I always feel like shame is a motivating factor.